Imagine for a second that you are sitting in your doctor's office. You've finally gotten a diagnosis for a highly sensitive, incredibly painful issue that has just been completely disrupting your sleep, your daily comfort, your intimate relationships.
Yeah, the kind of issue that just takes over your life.
Exactly. And your doctor hands you a prescription for a heavy-duty medication. You feel this massive wave of relief. You go to the pharmacy, pick up the box, and you open it up. But right there, printed in bold on the warning label inside the box, it explicitly tells you not to use this medication on the exact part of your body your doctor just told you to apply it to.
It's just the ultimate mixed message.
Yeah.
I mean, you are staring at a glaring, legally mandated warning label that directly contradicts the specialist who just examined you.
Right. It says do not use on genital skin, yet that is exactly where the clinical guidelines say it needs to go.
And the immediate psychological toll of that moment is immense. It basically forces the patient into a state of paralysis right when they most need to start their treatment.
It's wild. But the data we're looking at today unravels this massive contradiction. Because if you're dealing with lichen sclerosus or LS, you are already facing a grueling, chronic, inflammatory condition.
You're exhausted already.
Right. So today in this deep dive, we are pushing past the terrifying warning labels and the information overload to answer one central question based on the clinical data. How long does steroid treatment actually take to work for lichen sclerosus?
That really is the central question. And to get there, we have to look at the gold standard timeline for relief and, more importantly, the underlying mechanisms that make that timeline an absolute necessity.
Because understanding the mechanism is the only way to overcome the fear of that warning label.
Exactly. And we know who is listening. You already know what LS is. You know the severe itching that peaks at night, the white patches.
The fragile skin, the microscopic fissures.
Right. We don't need to rehash the physical symptoms. What we really need to explore is the why behind the clinical protocol. Why a specific ultra-potent medication? And why does the timeline look the way it does?
Okay, so let's unpack this, because to understand the timeline, we have to look at what the medication is fighting at a cellular level, right?
Yes, and the clinical data emphasizes a mechanism known as the Koebner response.
The Koebner response.
We know friction or trauma triggers the disease process.
Yeah.
But we have to look at what's actually happening beneath the surface.
Well, wait, if the surface issue is that the skin is dry, tight, and tearing, my instinct is just to, I don't know, throw a really heavy, high-quality barrier cream on it and be done.
I mean, that makes logical sense, but instinct is often a poor guide in autoimmune and chronic inflammatory conditions.
Fair enough.
Think of the Koebner response as an amplification loop. When the kid experiences friction, even something as mundane as wearing a panty liner or the microscopic irritation from urine, it sends a distress signal.
Okay.
In a normal immune system, that signal promotes healing. But in LS, that signal recruits this army of overactive T cells to the area. And these T cells start releasing inflammatory cytokines, which mistakenly attack the structural proteins of your own skin.
Wow. Okay, so the best way I can picture this localized immune overreaction is that it's like a deep, smoldering underground root fire.
Oh, that's a perfect analogy.
You know those forest fires that burn beneath the soil in the root systems? You might only see a few dead patches of grass on the surface, but underneath, the ground is literally an inferno.
Yes. So those emollients, those heavy moisturizers you mentioned, they are fantastic for the surface. They soothe that top layer.
But they're essentially just throwing a bucket of water on the topsoil.
Right. They do absolutely nothing to switch off the immune response raging below the surface.
So what's fascinating here is how the clinical guidelines structure the attack on that underground fire.
To actually extinguish that deep inflammation, you need an agent that can penetrate deeply and shut down that localized T-cell overreaction.
The heavy hitter.
Exactly. The undisputed champion in the clinical literature, which is endorsed by the British Association of Dermatologists and Specialized Women's Health Clinics, is a very strong, ultra-potent topical corticosteroid.
Typically clobetasol propionate 0.05%, right?
That's the one. Mild or moderate steroids simply do not have the biochemical strength to suppress this specific level of aggressive cellular activity.
So if we know we need the heavy hitter, that brings us back to our main focus. How long does the steroid treatment actually take to work?
Well, the data points to a highly structured, intensive 3-month boot camp. It is far from an overnight fix.
3 months. Okay, so how does that break down?
Month 1 is the suppression phase. You apply the ointment once every single day.
Every day for a month. Got it.
Then month 2 is the weaning phase, so you step it down to alternate days. And by month 3, you taper down to the minimum effective dose, applying it just twice a week.
Okay, but looking at the patient reports within the clinical data, the reality of that first month sounds pretty brutal.
Setting expectations here is vital. The primary goal over these 3 months is to stop the architectural damage, to halt the fissures and stop the intense pruritus or itching.
Right, though the white discoloration might remain permanently.
Yes, but the tissue returns to a normal, supple texture.
Yeah.
However, the first 1 to 2 weeks can be remarkably uncomfortable.
And looking at the data, there's a paradox here that makes zero sense to me. We are applying a potent, active pharmaceutical ingredient to microfissures and fragile, torn skin. Biochemically, shouldn't that cause severe stinging?
It absolutely does.
So how do patients even tolerate the first week? I mean, if the medicine meant to heal the burning actually makes it worse initially.
It requires immense persistence. You are completely right about the biochemistry. Introducing an active compound to a compromised skin barrier will trigger nociceptors.
The pain receptors in the skin.
Right. But as the ultra-potent steroid permeates the tissue and begins to inhibit the synthesis of those inflammatory cytokines over the first week to 10 days, the localized swelling and nerve irritation actually settle down.
Because the immune system is no longer actively destroying the new cells trying to bridge the gap.
Exactly. The microfissures begin to close. The initial stinging is just the price of entry for long-term structural healing.
Here's where it gets really interesting, though. We constantly hear in the broader medical and skincare world that using strong steroids thins your skin. It causes atrophy.
That is the single biggest driver of steroid phobia.
Right, but we just established that lichen sclerosus also thins the skin and makes it fragile. So aren't we fighting fire with fire here, applying a skin-thinning medication to already compromised skin?
It raises such an important question. We really need to differentiate the mechanisms of atrophy.
Okay, how so?
Prolonged, inappropriate use of an ultra-potent steroid on healthy, non-inflamed skin will inhibit fibroblast activity.
And fibroblasts are the cells that make collagen and elastin.
Correct. If you shut them down unnecessarily, the healthy skin thins out.
Right, the classic side effect everyone's afraid of.
But in the environment of lichen sclerosus, those overactive T cells we talked about are actively destroying collagen and elastin at a rate far faster than a steroid ever could. The untreated disease is literally dissolving the structural architecture of the vulva, which leads to severe scarring, narrowing, and permanent anatomical changes.
The underground fire is just burning away the foundation.
Yes. So when you apply the ultrapotent steroid to this specific environment, it acts as an immune suppressor. It neutralizes the T cells.
And by stopping the inflammatory destruction.
The steroid actually allows the surviving fibroblasts a chance to rebuild. Counterintuitively, by halting the inflammation, the steroid provides the environment necessary for the skin to regain its normal thickness and structural integrity.
Which completely shifts the perspective on that terrifying warning label. You open your prescribed box of clobetasol propionate, and it screams at you to avoid genital application.
And the specialists are definitive on this. Ignore that generic label.
It's just a broad strokes regulatory requirement, right? Designed to stop someone from using a super strong steroid on a minor, non-specific rash.
Exactly. And lichen sclerosus is not a minor rash. It is a severe, tissue-altering autoimmune condition. The data overwhelmingly shows this is the most evidence-based treatment available.
But ignoring the label requires a massive leap of faith for the patient.
It does. And this psychological hurdle often leads to self-sabotage. Patients read the box, they experience that initial stinging we discussed during week 1, and they panic.
They freak out and undertreat themselves.
Right. They might apply a tiny smear once a week instead of daily during that crucial first month of the boot camp.
Thinking they're being cautious, but they're actually allowing the disease to win. The inflammation continues, the architecture of the skin continues to degrade, and they're just stuck in a state of prolonged suffering.
It's tragic, really.
So how do we use it safely to ensure we don't cross the line into those systemic side effects? The clinical data offer some very clear application mechanics, right?
Yes. First, ointments are vastly superior to creams.
Because creams contain water.
Exactly. The science here is simple, but crucial. Anything with water requires preservatives to stop bacterial growth in the tube.
And those preservatives are notoriously irritating.
They're often the main culprit behind severe stinging and contact dermatitis. Ointments, on the other hand, are greasy, lack water, require fewer preservatives, and act as an occlusive.
Which helps the active steroid penetrate the skin deeper.
Right. The application technique itself is also a built-in safety mechanism. The dermatological guidance relies on the fingertip unit.
So for LS, you apply the ointment sparingly, roughly 1 to 2 pea-sized blobs.
Which is about half a fingertip unit, to cover the entire affected area. You are targeting the active disease, not slathering it on like a daily body lotion.
And there is a brilliant, highly practical metric in the clinical guidelines to help you monitor your own safety. I call it the golden rule of the tube.
Oh, the 30-gram rule. It's so helpful.
Yes, one standard 30-gram tube of this ointment should last you at least 3 months. It is such a brilliant way to visually control your dosage.
If you are burning through a 30-gram tube in 4 weeks, your application is far too thick.
But if a single tube lasts you 3 months or more, the data explicitly states that systemic absorption or medication-induced skin thinning is highly, highly unlikely.
That volume metric empowers the patient. It takes the guesswork out of the word sparingly.
Totally.
And while the steroid is doing the heavy lifting, we cannot ignore companion care. You brought up the bucket of water earlier. You still need that water.
Emollients, right. Barrier ointments like plain Vaseline or Epiderm.
They are vital. Urine is a massive irritant. It contains urea and uric acid, which can easily trigger that Koebner amplification loop on fragile skin. The emollient acts as a physical shield against that irritation.
But the order of operations is completely unforgiving here. It's exactly like a high-end, highly active skincare routine.
That's a really good way to look at it.
You know, you always apply your expensive active serums first, allow them to fully absorb into the dermis, and only then do you lock it all in with a heavy barrier cream.
Exactly. With LS, you must apply the steroid ointment first. Then, you have to wait a minimum of 30 minutes before applying your barrier emollient.
Because if you apply them simultaneously or in the wrong order, you just dilute the ultra-potent steroid.
And it will never reach that underground root fire.
Right. Okay, so if we connect this to the broader journey of chronic disease management, there's a pretty harsh reality waiting at the end of month 3.
The transition phase.
Let's say a patient follows the rules. They brave the initial stinging. They use their 30-gram tube perfectly. Their skin feels normal. The nocturnal itching is gone. The structural tearing has healed.
The psychological instinct is to declare victory and toss the rest of the tube in the trash.
But you can't, because lichen sclerosus is a lifelong chronic condition.
Unfortunately, yes. Aside from a small subset of childhood-onset LS that sometimes resolves by puberty, there is no permanent cure for the adult-onset form.
So after you finish the intensive 3-month boot camp, you basically transition into the long game.
You enter an individualized maintenance regimen, which for most patients means applying that steroid ointment twice a week, indefinitely.
Indefinitely is a heavy word for a patient to process.
It really is.
Ah.
But the clinical data tracking relapse rates is stark. Longitudinal studies from 2013 and 2016 followed patients over a 52-week period after their initial treatment phase.
And what did they find?
The patients who adhered to proactive, twice-weekly steroid maintenance experienced a relapse rate hovering near 0, up to a maximum of maybe 8%.
Wow, that is profound disease control.
But the other side of that data is what happens when people try to manage it naturally or just with moisturizers after the initial flare is gone.
Oh, no.
Yeah. The patients who relied solely on emollients experienced a massive 56 to 62% relapse rate within that exact same year.
Just by stopping the active medication, they let the T cells slowly rebuild their forces until the underground fire reignited.
Which completely reframes the concept of maintenance. We often use simple analogies for daily habits like brushing your teeth, but this requires a much more structural mindset.
Right, it's not just brushing your teeth. It's much more like managing the water pressure in an aging dam.
Oh, absolutely.
You don't just patch a massive crack in the concrete once, pat yourself on the back and walk away. The pressure of the water, the immune system in this case, is constant and unrelenting.
That is an incredibly accurate way to view the biomechanics of it.
If you don't actively regulate the pressure valves twice a week, microfissures will form again, and eventually the structural integrity of the wall will fail entirely.
You are constantly regulating the pressure. And there is a far more profound why behind this lifelong regulation than simply avoiding the discomfort of an itch.
The cancer risk.
Yes. Uncontrolled lichen sclerosus carries a small but highly significant risk of developing into vulval squamous cell carcinoma. The clinical literature generally puts this risk at less than 5%.
So, wait, what is the exact mechanism connecting the itch to a malignancy? How does an immune condition turn into cancer?
It really comes down to cellular turnover and chronic inflammation. When the immune system is constantly destroying tissue, the body has to constantly generate new cells to replace it.
Okay, that makes sense.
Chronic, unchecked inflammation creates an incredibly hostile, volatile environment. The faster cells are forced to divide and repair in a toxic, inflamed environment, the higher the mathematical probability that a cellular mutation will occur and evade the body's natural tumor suppressors.
So by keeping the inflammation suppressed with the twice-weekly steroid, you dramatically reduce that volatility.
Exactly. It shifts the entire goal of the treatment.
So it's not merely symptom relief, it is active cancer prevention.
Precisely. The maintenance regimen is preventative oncology just as much as it is dermatology.
Which brings up a really interesting angle regarding alternative therapies. If you are researching LS deeply, you are going to encounter a lot of buzzwords promising high-tech solutions.
The regenerative therapies.
Right. Things like fractional CO2 laser therapy, radiofrequency, PRP, which is platelet-rich plasma, and polynucleotides. The specialized clinics in the data acknowledge these, but their positioning is highly deliberate.
Very deliberate. The clinical consensus treats these purely as adjunct therapies, never as primary replacements for the steroid protocol.
And if we look at how these technologies work, it makes perfect sense.
Exactly. Therapies like fractional lasers or PRP work by intentionally creating microtrauma or introducing growth factors to stimulate fibroblasts and increase blood flow to the surface tissue. They are regenerative.
But wait, in a disease where trauma triggers the Koebner response, isn't inducing microtrauma with a laser incredibly risky?
It is a phenomenal point, and it highlights exactly why the medical community approaches these with such caution. The evidence for these treatments in LS is highly mixed, the studies are often very small, and the protocols are just not standardized yet.
So if you use a regenerative therapy while the T cells are still highly active,
While the underground fire is raging.
you might just trigger a massive Koebner flare-up.
Precisely. So the mantra is suppression first, regeneration second. You do not try to rebuild the house while it is still actively on fire.
You complete the 3-month steroid boot camp, you establish baseline control.
And then, if you are strictly maintaining your twice-weekly steroid protocol, but still struggling with specific issues like localized tissue fragility, these adjuncts might offer symptomatic relief.
But they do not reprogram the local immune system. Only the ultra-potent steroid is proven to do that.
Right. If we connect this to the bigger picture, looking at this entire timeline, from the first day of month 1 to year 10, the overarching theme is a total shift in patient mindset.
You're no longer reacting to an acute illness, you are managing a lifelong physiological environment.
Yes, this means adhering strictly to the maintenance schedule, but it also mandates lifelong self-examination. The patient must become an expert on their own anatomy.
So you have to know the baseline appearance of your skin so you can spot any unusual thickening, persistent sores, or architectural changes early.
Exactly. And you must maintain regular, specialized medical checkups.
So, what does this all mean when we distill the timeline and the data? The critical takeaway isn't just about applying an ointment. It's about deeply understanding the tools you are using to take back control of your health.
Lichen sclerosus is a chronic, deep tissue immune reaction.
Right. And the primary timeline to extinguish that acute flare is an intensive 3-month steroid boot camp. A single 30-gram tube should be your metric for safety, lasting you through those 3 months.
And surviving that boot camp isn't the finish line. It is the entry point into a lifelong, twice-weekly maintenance routine designed to preserve your anatomy and prevent malignancy.
Navigating this condition successfully means learning when to trust the specialized evidence-based science over the broad generalizations of pharmaceutical packaging.
It is about intellectual empowerment in the face of medical fear.
Which leaves me with a final thought for you to mull over. Think about the incredible power of the mind-body connection and how information itself is delivered in modern medicine. How much actual physical suffering in chronic conditions could be completely avoided simply by improving how medical packaging and warning labels are communicated to patients.
It's a profound question.
If a generic, legally defensive label terrifies someone into abandoning a safe, highly effective, potentially life-saving treatment, isn't the information itself acting as a barrier to healing? The next time you open a box of medication and see a terrifying warning, remember the underground root fire. Sometimes the only way to put out the fire underneath is to possess the knowledge to confidently ignore the label on the box.